Welcome to today's Explainer. I am absolutely thrilled you're tuning in because today we are taking a seriously fascinating journey into the microscopic world of our own biology. Think of this explainer as your rapid-fire crash course in cracking the secret medical code of oncology. We're going to explore neoplasia, which literally just means new growth, and figure out exactly how and why our body's cells sometimes decide to entirely rewrite their own programming. If you've ever stared at a medical chart or listened to a doctor drop incredibly dense, intimidating jargon and wondered, okay, but what does that actually mean? Well, you are in the exact right place. All right, let's take a quick look at our roadmap for today. First up, explaining the crab. Second, one cell goes rogue. Third, cracking the medical code. Fourth, when cells forget themselves. And finally, the path to malignancy. Let's dive right in. Section 1. Explaining the crab. The origin of cancer. To truly wrap our heads around the biology and the terminology of this disease, we first need to take a quick step back and look at its incredibly bizarre history. I've got to ask you this. Why on earth do we use the word for a marine crustacean, a crab, to describe a deadly, complex human disease? It seems completely random, doesn't it? But there's actually a highly specific visual reason for this, and it goes back thousands of years. So picture this. The ancient Greek physician Galen was observing an infiltrating tumor, and he noted something profound. He saw that the swollen, vein-like sores radiating out from the central mass looked exactly like a crab's legs reaching outward into the water. Because of this incredibly vivid resemblance, he used the Greek word karkinos, which literally translates to crab. The Latin translation of that exact word gives us the modern term we use today, cancer. It's literally an idiom born from the grabbing, infiltrative behavior of the disease itself. Pretty wild, right? Moving on to Section 2, one cell goes rogue, microscopic origins. Okay, now that we've got the ancient history down, let's shift our focus to the biological origin story. To ground us, let's look at the absolute gold standard definition of a neoplasm, courtesy of the renowned British oncologist Rupert Willis. He said, "A neoplasm is an abnormal mass of tissues, the growth of which exceeds and is uncoordinated with that of the normal tissues." The crucial part is what he says next. He notes that this growth persists in the exact same excessive manner even after the initial trigger is completely gone. It becomes totally autonomous. It ignores the body's stop signals and just keeps on dividing. And the clonal theory of cancer development explains exactly how this autonomous growth kicks off. Imagine a group of perfectly healthy tissue. Now, just one single cell inside that tissue might sustain a genetic alteration. Just one. But because that specific mutation gives it a selective growth advantage, it goes completely rogue. It starts aggressively dividing, multiplying, and passing that heritable genetic alteration down to its progeny. Eventually, you don't just have one rogue cell anymore, you've got a massive, autonomous monoclonal colony that has entirely taken over the neighborhood, which eventually paves the way for metastasis. Section 3, cracking the medical code, translating tumor names. All right, this is where we get highly practical. Pathologists actually name tumors based on their cell of origin and their biologic behavior. Consider this your secret decoder ring. If a growth is benign, meaning it's localized and generally less dangerous, it usually gets the suffix -oma. So a benign tumor of fibrous tissue is just a fibroma. But if that rogue mass is malignant, the code completely changes. If it starts in epithelial cells, like the linings of our organs or skin, it gets the suffix carcinoma, like adenocarcinoma. If it arises in mesenchymal tissue, think fat, muscle, or bone, it gets the suffix sarcoma, like an osteosarcoma. Once you know this rule, a highly complex medical chart suddenly makes a whole lot of sense. But hey, it's medicine, right? There are always exceptions to the rules. And in this case, the rule breakers are incredibly dangerous. Listen to these names: melanoma, lymphoma, hepatoma, seminoma, myeloma. If we strictly follow our new decoder ring, that oma ending should mean these are completely benign, but they are absolutely not. These are historical exemptions to the naming system, and every single one of them is dangerously malignant. This right here proves just how vital it is to crack this medical code accurately, because mistaking a melanoma for a harmless growth just based on its name would be a catastrophic error. And speaking of exceptions, there is a truly bizarre category of mixed tumors, and the absolute most famous is the teratoma. A teratoma arises from embryonic totipotential cells. These are stem cells that possess the extraordinary ability to differentiate into absolutely any germline in the entire human body, ectoderm, mesoderm, or endoderm. So, when these specific cells mutate and go off script, they don't just form some amorphous lump of tissue, they literally try to build body parts. The result of those totipotential cells going wild is something like an ovarian cystic teratoma or dermoid cyst. Because these mutant cells differentiate along ectodermal lines, they actually grow distinct formations of hair, fat, and get this, fully formed teeth right inside the tumor mass. It's shocking, for sure, but it perfectly highlights the unbelievable chaotic power of our cellular programming when it completely derails. Section 4. When cells forget themselves. Descent into chaos. So, we've decoded the names, but to understand what's actually happening inside the structure of these rogue cells, pathologists look at two main concepts: differentiation and anaplasia. Differentiation is basically how much a tumor cell resembles its normal, healthy counterpart. A well-differentiated benign cell remembers its day job. A benign tumor of smooth muscle still acts and functions a lot like normal smooth muscle. But anaplasia? That literally translates to form backward. Anaplastic, malignant cells completely lack differentiation. They've entirely forgotten what they are supposed to be, reverting to this primitive, unspecialized, and highly destructive state. So how do we actually spot anaplasia? Well, pathologists look for very specific markers of this cellular chaos under a microscope. The first is pleomorphism, which is just a fancy way of saying there is an extreme, wildly unpredictable variation in the size and shape of the cells. The second is hyperchromasia. The nuclei of these cells become incredibly dark and oversized because they are just crammed full of excessive, abnormally dividing DNA. And finally, there is a totally disturbed architectural orientation. Normal cells line up neatly. Anaplastic cells grow in a disorganized, chaotic jumble. They've completely lost their internal compass. Finally, Section 5. The path to malignancy, a stepwise timeline. Now, the really important thing to understand here is that this cellular chaos, this anaplasia, it doesn't just happen overnight. It follows a distinct stepwise pathogenesis driven by the progressive buildup of DNA damage. A normal tissue might first experience hyperplasia, which is just an increase in cell numbers. Under stress, it might undergo metaplasia, swapping out one cell type for another. But as genetic alterations continue to pile up, it warps into dysplasia, a disorderly non-neoplastic proliferation. If the damage isn't stopped, that dysplasia crosses the point of no return into full-blown anaplasia, resulting in malignant infiltration and, eventually, metastasis. It's a step-by-step descent. Let's ground this biological progression with a real-world example, the natural history of cervical cancer. The timeline here is actually astonishing. It all starts with a persistent HPV infection. Over a few months, this can cause CIN1, which is mild dysplasia. But here is the critical window. It can literally take decades for this to progress to CIN3 or carcinoma in situ, where the severe dysplasia involves the entire thickness of the epithelium. From there, it can take another 1 to 15 years to become truly invasive cancer. This incredibly long delay is exactly why preventative screening is so spectacularly effective. The visual progression of this is just striking. In the early stages, like CIN1, those dark, dysplastic cells are confined to the very bottom layer, while the cells up top remain relatively uniform and organized. But as it progresses to carcinoma in situ, the chaotic, dark, mutated cells completely take over, from the bottom all the way to the top. The architectural orientation is utterly destroyed. It is a total takeover of the epithelial layer, sitting right on the brink of invading the deeper tissues. Which really leaves us with one final, incredibly provocative question. If we can decode this secret medical language, if we can identify the visual markers of anaplasia, and if we can track a rogue cell's progression over a timeline spanning decades, how close are we to intercepting every single cancer before it truly begins? Understanding this dense cellular code isn't just about passing a biology test. It is the absolute, ultimate first step to defeating the disease entirely. Thank you so much for joining me on this explainer. Keep asking those big questions, and I'll see you next time.